Welcome to Healthcare Experience Matters. This podcast is brought to you by the Healthcare Experience Foundation and is dedicated to transforming the healthcare experience so that every person can receive and deliver the best care. We invite you to learn more by visiting healthcareexperience.org.
My name is Katie Owens. I get to serve as our president and co-founder here at Healthcare Experience Foundation. We're focusing our time and attention around supporting and equipping you with strategies to better prepare your residents, physicians, and physician leaders through enrichment programming. And I'm thrilled to be teaming today with Drs. George Mayzell and Dr. Rob Minkes from our team. Just a moment, I'm excited for you to get to meet our physician coaching team, Dr. Mayzell, Dr. Minkes. Let me get out of the way and ask Dr. Mayzell to introduce yourself first.
Thanks, Katie. Welcome, everyone. My name is Dr. George Mayzell. Brief introduction. My background's internal medicine, geriatrics. I was in practice for about a dozen years, give or take, and then moved over to the dark side at one of the payers for many years. And then also from there was chief medical officer at a number of hospitals, system level in a bunch of different cities, CEO of a clinically integrated network, and then consultant at chief clinical officer at Vizient Southeast for a while. And again, happy to be working with Katie, who she and I go way back for many years now, doing a lot of coaching, a lot of physician leadership, a lot of patient experience stuff, which has been great fun. Thanks, Katie.
Yeah, hello, welcome everybody. I'm Rob Minkes, and my background is in general and pediatric surgery. I spent over 20 years in clinical practice and have been in healthcare leadership for over 20 years also. Currently, I'm a full-time physician coach and consultant and have been working with Katie and George and the team for 3 years at the organization I worked with on patient experience and joined the team during the end of last year. So happy to be here.
Yeah, and Rob, you notice I was careful not telling everybody how many years I did each thing so they could add them up. You weren't so careful.
Concurrent years.
There you go. We put this program together a number of years ago. And really, the goal was to help residents and ultimately attendings and faculty get better at all the stuff that's not clinical medicine. As you know, most of us don't get trained in those kind of things. And so we wanted to sort of focus on all that stuff that makes you a better doctor, helps you with resiliency and burnout, and gets you to the finish line that's not, the clinical knowledge that we all need. And, you can see from the graphics on the right, we had great results. Look at the significant improvement in all those categories of ACGME that are measured. All those are plus, some great results, which we'll go into a little bit more detail later. And again, the verbatims on the left side, helpful and helped me foster my leadership skills. We spent some time on that. Key takeaways for me were, just reminding folks of the compassion and the empathy and things that we all went into medicine with, but sometimes get lost, especially in a couple of COVID years. And then also sort of getting docs and residents and students to sort of think about emotional intelligence and things that are really go along with IQ and clinical knowledge to make them a great clinician and to get, better outcomes from patients. So that's the takeaway message here. Diving down sort of into a little more detail here, these are some of the topics that we really spent some time on. And as you know, diversity, equity, and inclusion are huge issues right now. Everybody's focusing on them. How do we get better, understand our own biases, and really make sure that we're getting the best results with folks that are different than us and how we communicate. We talked about healthy conflict and giving feedback, certainly some things that, again, critical to being in the learning journey as a physician and any type of clinician, but really aren't taught. Patient experience, again, how to do a better job. And we know it takes time. We didn't very intentionally focused on things that we're not going to add time to the clinician visit. Emotional intelligence, I already mentioned, teamwork, and then of course, we all know burnout resiliency is a huge issue, even starting at med students and residents and going into, in physicians and practice. And again, any tools we can give folks to help mitigate some of that risk is highly valued. And again, will show great returns in the long run. And one of the things we found in teaching the residents is that the faculty came back and said, we thought we knew all this stuff, but, we didn't know this as well as we thought we did. So again, that was very helpful. And then we went, backwards and said, okay, let's work the faculty into some of the educational process. Because again, as you know, in medical school and residency, the focus is on understanding the clinical care and sometimes not the delivery of care. And that's what this program really focused on.
So if we take a couple moments to reflect on the current state, it's no surprise to anyone here. You can't open up a health-related email or journal or program and not hear about the current crisis we have in healthcare and trying to balance healthcare-related well-being and really successful outcomes. And this slide shows the 2022 data from the Mayo Wellbeing Index. They had over 110,000 participants. And what this illustrates that those who are at a high level of distress for physicians, that's over 38%, residents and fellows, 20%, medical students over 30%, APPs near there, that the risk of burnout is quite high, anywhere from 3 to 9 times higher. And this relates also to an overall poor quality of life, recent medical error risk. And you can see for residents and physicians, there's an increase in suicide risk. And for medical students and APPs, they're thinking about quitting. And we know the crisis. And this also carries into nursing. So we really are in a state of crisis where we believe that we have to change the focus, do things a little bit differently. And here's a great quote from Dr. Mayzell, where he points out that we're working to really work on these non-clinical behaviors and skills so we can not just be better physicians, which we will be, but really to mitigate some of these risks and to be better prepared to deal with this as we go into practice. It's about making happier patients with better experience and happier doctors who can focus on what we need to do for success. So this gets to really our why, and that's the heart of the matter of doing what we do. It's focusing on these core human qualities that will enrich our lives to better be able to focus on the important outcomes. So we know that physician burnout has been steadily increasing. And here's a study by Dr. Mayzell showing an increase from 2011 to 2014 in the components, the defined components of burnout. And we know there's more recent data showing that burnout is upwards of 60%. For example, some of the data from that Mayo burnout study shows that that the burnout is high across the board. In addition, residents experience at least one of these symptoms, and it's higher than 45% now. And key to this, there's also emotional problems related to anxiety and stress and even depression. This is important for organizations because the well-being of our physicians really relates to the patient experience overall. And physician loyalty is dependent on our administration's responsiveness, how we care for our patients, and really how we relate our patient care relative to safety issues. And we're all working for the quadruple aim, and we believe that going beyond the framework of a quadruple aim and recognizing the problems, that we have real solutions to help to intervene. So we know that this has been a problem even before COVID, and COVID has just escalated the issue. So emotional exhaustion, everybody is tired, right? But we've gone beyond tired. It's impacting our well-being, right? We have low personal accomplishment. Even though there's meaning in the work that we do, it impacts us very deeply in the way that we interact with others. And we have trouble relating to the patient. So empathy and compassion are at risk with this current crisis. And so burnout might not be the right term because there are so many components. And I'm going to ask Dr. Mayzell if he can share his thoughts and take us to the next section.
Yeah, the whole term burnout really kind of offends me and offends, I think, most clinicians and physicians because, we're a pretty resilient group. We went through, med school, we went through residency, we had a lot of sleepless nights. We're a pretty resilient group. So to say, and burnout sort of implies sort of a personal failing. And again, it's the wrong term. We use it because everybody knows what it means, but this is really a mismatch. It's really more about disillusionment. The term moral injury has been kicked around because it's really not about taking care of patients that is making everything challenging. It's all the stuff that gets in the way, the insurance plans, the payment models, some of the clinic staffing models, some of the new employment models with private equity and what we call payviders involved and hospitals. I mean, all these things, and again, they're all a little bit different, but they all can and sometimes do get in the way of taking good care of patients. And that's the stuff that's causing physicians to burn out. So we'll use that term. I don't like the term, but it is sort of, people know it and understand it, but I think it's really the wrong term for what we're talking about here. So now we're going to shift a little bit and sort of talk about, sort of matching this up to the ACGME standards. And as we do that, we really look back, as I think Rob mentioned. Physicians and providers, we spent all this time learning about the Krebs cycle and learning about congestive heart failure and whatever. But we don't spend any time really in medical school talking about taking care of patients, talking about the business side of medicine, and talking about leadership. And again, I think we have to acknowledge that when we talk about business, we're not necessarily talking about business in the sense of business and management. We're talking about how to get good care for patients, how to deal with patients in difficult situations, and all the things that go around being a great clinician that don't have to do with being clinically skilled and clinically excellent. We all know docs out there that people love and think are wonderful physicians, and they may or may not be the best clinicians, but they're sometimes the best folks that relate to people. So what we want to do is match those skills together. And I like this diagram because I think it's very illustrative. And I always start at the bottom here because that sort of makes the most sense to me. When you're a medical student, most of your knowledge and time and energy is all understanding the clinical stuff. So it's all that technical, understanding all the disease process, understanding, how to diagnose, understanding how to treat. As you move up to be a resident, ultimately an attending, you can see the technical stuff gets a little bit smaller and some of the relationship stuff gets bigger. And this is a relationship with patients, this is a relationship with peers, relationship at the hospital level with the staff there, maybe relationship with payers, all those things that get things done in healthcare. And then as you move up to more leadership roles, we see that business and strategy take over because you have to understand, other things besides just the technical side. And I always sort of talked about, physicians' leadership is, as you get in a leadership role, you're an inch deep and a mile wide rather than a mile deep and an inch wide. You're still providing great care for patients, but in a very different way. And we're all leaders. Even if you're a resident, you still have your med students under you. If you're an attending, you have a team under you also. Even when you're in practice in the hospital, perhaps the hospitalist, you're working with a team of nurses and APPs and phlebotomists and respiratory technologists and so on. So you're always, that leadership sometimes really gets lost, and it's something you really can learn. Some people are born with it, which is great, but they can get better. And some people could get really good at it just by learning how to do it well. So those are some of the things that we talked to residents and attendings of this program went on.
We were at the ACGME conference a couple of weeks back in Nashville and must have had 30 conversations over this slide, which was visible to everyone, which compares some of these core human competencies with the core competencies from the ACGME, which are listed on the left. As you can see, that what we're doing is not the medical knowledge. We've been pretty good at passing on medical knowledge in medical school and residency and preparing physicians for the technical aspects of being a physician. But if you look at the skills, emotional intelligence, communication, compassion and empathy, dealing with conflict and teamwork, diversity, equity, inclusion, and belonging, and also seminars that focus on these really help to augment the core competencies from the ACGME. I have a colleague who we just were talking recently, who is a physician, internal medicine physician, who worked on many of these aspects and noticed an incredible increase in his patient experience scores. And his takeaway wasn't that these things make a big difference. His takeaway was that he thought he was already doing a good job with it. And so there's so much more and so many more opportunities we have in this areas. So that being said, with this as a backdrop, we'd like to launch a poll and ask, of the skills that we've discussed so far, which do you believe that your physicians and residents would most benefit from?
Well, interesting results here, because diversity, equity, inclusion sort of is the and healthy conflict and teaming are the sort of two outstanding ones, and then the other ones are sort of all there. And again, I think we would acknowledge all of these are important, and prioritize them is probably a little bit academic more than, because you sort of need them all. The other thing I think I wanted to add that Rob mentioned, for what Rob mentioned about patient experience, the other thing we know is when patients have a better experience, generally the physician has a better experience too. And I think that's kind of an important thing. So physicians tended to be more satisfied when their patients had a better experience. So it's not one-sided. Okay, let's talk a little bit about learning priorities. And again, we already mentioned some of these things. One of the things we wanted to do is really, as we built this program, there was a lot of iterations to this program, working with the stakeholders, since this was sort of new stuff, and then circling back as we learn things, and then, really a train the trainer mode. As I already mentioned, we started this with some of the residents, and then a lot of the attending folks, physicians and others, felt like, oh, wow, there's an opportunity. We don't know as much as we thought we did, so let's do some programs for them as well. And then we've also, in other situations, other areas, done these programs where we've had joint programs with APPs and physicians, which really add some value in teamwork training, since, as you know, healthcare delivery is really becoming a team sport. So a lot of exercises. These are a lot of open mic sessions. It was a little challenging to do some of these over COVID because it changed from the in-person to virtual in pretty much all cases. And, a lot of breakout sessions and a lot of discussions. And you can see some of the things on the right side of this on the exercises that we did. And you can see year 1 up at the left side and year 2 and 3 at the right side. And you can see a lot of the, looking at leadership, looking at emotional intelligence, looking at compassion and communications early on. And then in the later years, again, leadership, resiliency, teamwork, professionalism, psychological safety, service recovery, key performance measures, and diversity, equity, inclusion. And we also did some practical sessions on, what happens when you leave residency and become an attending, and some of the things that really change in that environment, and some of the tools to deal with some of the new things that those folks are now faced with. So again, a lot of iterations and feedback to these programs as we kept sort of getting feedback with each session, and then making each session hopefully more accommodating to the audience's needs. And again, I think you can see it here. In addition to the regular discussions, either on-site or virtual, there was also a lot of content online that was available with small videos, small PowerPoints, and other things, some survey items to evaluate one's own self in some things. And there's a lot of online tools that folks could go on demand and evaluate. Rob?
So a big takeaway, I think, from here and from the ACGME was the common recognition that we all know there is an issue. And it's time to do things differently, that we need to put the energy, the resources, and the organizational approach to making a difference. And this goes beyond just training our leaders. Many organizations train leaders. But what's most important is that we need to start with our medical students, with our residents, and with the faculty who are going to be interacting with them and can ultimately learn these skills and pass them along. That's been missing probably in healthcare training for the last 150 years, right? We've been doing it the same way since modern day residency programs existed. And so as George pointed out earlier, this is about well-being and results. They're tied together. And he gave you the punchline at the beginning, but by making an organized approach with a proper framework, we can make a real difference in these categories.
All right. And a reminder on the screen to say the date for next webinar, physician onboarding and retention. And we all know how critical onboarding is to keeping docs. And last data I saw that losing a doc has cost the system about $1 million for the, I should say $250,000 to $1 million when you lose a physician in a big system. So, and onboarding is a big piece of keeping docs inside a system. So
one question that came in about 5 minutes ago to me was, how did we work with the GME teams to incorporate this content into the resident education programming?
I'll take first crack at that, but Katie, you're probably the best one to answer that. A lot of it was back and forth dialogue. The residency, after we developed the curriculum based on sort of that back and forth conversation, the residency directors gave the folks, residents, some protected time and a session, and that we could actually meet and talk. We did, again, some in person, pre-COVID, and then post-COVID, we did a lot of virtual. And then as we're sort of going back to doing some more in-person stuff now that the world has opened up. Katie, you want to add to that?
I think each GME program is unique, and in many instances, we work with time available on the GME calendar. In other instances, we are intentional to protect a half a day a quarter or a 1 day semi-annual retreat and bundle the programming based on what we learn through early diagnostic conversations. I think one other point, and Dr. Minkes, you saw this probably at ACGME considerably, also to create sustainability, we've implemented faculty train the trainer programs so that this content can be, and with the faculty, with the GME team, so that the content can be sustained over time.
And another thing that I heard multiple times at the ACGME were that there are increasing requirements for didactic hours that they're looking for content even to fill it with. And it seems like this was the perfect opportunity to line these types of programs up with the hours that they have allotted.
Thanks to all of you joining today and those of you that we know are watching on demand. So thanks for joining us today.
Thank you for listening to today's episode of Healthcare Experience Matters. Healthcare Experience Matters is brought to you by the Healthcare Experience Foundation. To learn more, please visit healthcareexperience.org. That's healthcareexperience.org.